Hello, my name is Jenna Maggard, and I am the president of the Idaho Intermountain chapter of the Association for Professionals in Infection Control and Epidemiology, otherwise known as APIC. I would like to welcome you to the fourth webinar in our 2012 APIC HAI Prevention Learning Network series, offered in partnership with Qualis Health. We have planned this series to bring you infection prevention information and expertise that addresses issues we face every day in our patient care world. If you have a subject that you'd like to see presented in the future, please take some time to pass along those ideas to us. Our emails are provided on the event flyers and on the slide deck handout. My colleague, Jennifer Pelagi, APIC board member and Qualis Health consultant, will share some brief housekeeping comments, and then I am excited to introduce our guest speaker, who I get to personally work with on a day-to-day basis. Julia has great expertise, and she's going to share some of her wisdom with our APIC network. So, Jennifer?
Thank you, Jenna. This is Jennifer Pelagi, a quality improvement consultant with Qualis Health, the quality improvement organization for Idaho and Washington. I thank you all for joining us today. We had a lot of registrants, probably around 200, and as they're all getting onto the lines, I just wanted to give you some brief housekeeping tips and things. Because we'll have so many registrants, we're going to keep all the lines muted during the presentation, but I do invite you to submit questions or comments in the chat section of your WebEx screen, and that's in the lower right corner when you're looking at it. We will also have a question and answer period at the end of the talk. I want to extend a special thank you to Acumentor Health, Oregon's QIO, and also to neighboring APIC chapters, state HAI coordinators, and hospital associations in helping us extend this invitation to healthcare providers across many settings in Idaho, Oregon, and Washington. Nursing continuing education credits are available for one contact hour as approved by the California Board of Registered Nursing. Those interested in receiving credit, please complete the sign-in sheet that was included with the handouts, and be sure to include your email address and nursing license number. If you're not an RN but would like a participation certificate, please let us know on the sign-in sheet. Those completed sign-in sheets can be emailed or faxed to me, and that is on the sign-in sheet. A CEU certificate will then be emailed to you in about a month or a month and a half. It takes a little time to process everyone. Handouts were sent to registrants ahead of time, and those are also available on the Intermountain APIC website. If you need it right now, shoot me an email at jenniferp@qualishealth.org, and I will send it to you right away. You will also be offered a brief online survey at the close of the presentation. Please complete it so we can continue to improve our offerings for you. Now let's focus on today's topic, antimicrobial stewardship and infection prevention. We are excited and very honored to have with us today national expert Julia Moody, an extraordinary infection preventionist who is a lead national expert and author on this and other infection control topics. Julia, you have our attention.
Thank you for the opportunity to work with you today, to present with you, and for taking time out of your very busy schedule for this learning event. We move on to our objectives on slide number 2 that we're going to be going through today. So it's a very comprehensive program to share with you the state of the art within antimicrobial stewardship, talk a little bit about antimicrobial resistance, and then just how your day-to-day duties relate to antimicrobial stewardship and how the great work that you are doing in each of your facilities is a benefit and improves patient outcomes. So let's start on slide number 3. We love case studies because they're such a great learning experience. And then this first case study on slide number 3 is really asking the question, how hardwired are your infection prevention practices in your facility? You may have actually experienced this particular case where a 35-year-old ventilator-dependent quadriplegic is a frequent admission to your facility. You are sharing this patient with an LTAC, and on this readmission, the patient's coming back to the acute care hospital, MICU, with pneumonia due to Pseudomonas aeruginosa. Unfortunately, this organism is resistant to all the antibiotics on the microbiology susceptibility test panel except for amikacin. Next event is that pharmacies have called to say that amikacin is not available due to a nationwide drug shortage. Colistin susceptibility has been requested at the lab, but it is pending. Next thing that happens, the bed supervisor is calling you in infection prevention for guidance because the staff working in the MICU have Googled this MDRO and are very worried about their own health as well as how to care for the patient. So your job is going to be to talk with the staff, to tell them and share with them what are the facts, what are the known control mechanisms. However, you know in your own heart and your own head that for this particular case, preventing transmission of this resistant MDRO is going to be reliant on highly compliant infection prevention practices. So let's move on to slide number 4. What we are all sharing is colonized and infected patients within the continuum of healthcare, whether it be in skilled facilities, acute care hospitals, sharing within your community, within other communities, ambulatory care settings, and even out into the communities with the different MDROs that we are now challenged with to treat and to prevent transmission of. So in this integrated healthcare system network, we have many different entry points and in many different points of transmission and sharing of these organisms within the healthcare setting. So there will be differences in MDRO rates between units, between different facilities, and even within the different regions of the United States or within your own locales of the types of MDROs, multi-drug resistant organisms, or the frequency of multi-drug resistant organisms. We move on to slide number 5. What is the magnitude of antimicrobial use? We know that antimicrobials are the second most commonly used class of drugs in the United States. More than $8.5 million are spent on anti-infectives. This is a big budget item on your pharmacy, your hospital pharmacy dollars. We know that outpatient use accounts for over 53% of the use of all antibiotics within the United States, and that up to 3 million antimicrobials are prescribed annually. 30 to 50% of all hospitalized patients receive antibiotics, and yet studies estimate that up to 50% of antibiotic use is either unnecessary or inappropriate across all types of healthcare settings. So on slide number 6, this is from a publication in the Archives of Internal Medicine studying the unnecessary use of antimicrobials in hospitalized patients. This was a prospective observational study in ICUs. Approximately 30% of antimicrobial days of therapy were actually deemed unnecessary. So what were these most common reasons of unnecessary days of therapy? The first bar graph shows duration of therapy longer than necessary, meaning there were opportunities to decrease the length of therapy. The next highest reason was for a non-infectious or non-bacterial syndrome. Not all fevers are caused by infectious agents, so this was another opportunity to really right-size what antibiotics were being used. And then the last opportunity that was found was treatment of colonization or where it was actually a contaminated specimen, so it was not indicative of the patient's infection at that time. So with this setting, we've known that there are plenty of opportunities with antimicrobial stewardship within the ICU as well as outside of the ICU. On slide number 7, we ask the question, why improve antimicrobial use? Because antimicrobial agents are misused in hospitals, and the misuse will adversely impact patients and society. Antimicrobials are the only drug where use in one patient can impact the effectiveness in others. So improving the antimicrobial use improves patient outcomes and saves money, and improving antimicrobial use is a public health imperative. In slide number 8, this is a slide deck off of some recent studies that were published, in that our arsenal available for new antibiotics, this pipeline is drying up. The number of new antimicrobial agents that were released for market use within the United States in the mid and late 80s was plentiful. There were new drugs that were released almost every month, or every year, excuse me. As we move forward to the current time, there are fewer and fewer antibiotics being developed by companies. And some of these drivers are actually due to marketing pressures, where if you develop a new statin drug, that patient in cardiology is going to be using that drug for a lifetime, versus antimicrobial agents, which are typically used for a very short window of time. So the new drugs that are coming out within the next year in this 4-year cycle have been primarily targeting resistant gram-positives. There are almost no anti-gram-negative new ones in the pipeline. In slide number 9, what are some of these opportunities that the antimicrobial stewardship team looks at? In antimicrobial stewardship, the clinical pharmacist and your physician champion are really the heavy lifting within the stewardship program. And infection preventionists and healthcare epidemiologists are collaborative supporting partners in this process. So the opportunities for antimicrobial improving that use is reducing the overuse and misuse. Areas to target are where drugs are given but not needed. If there's a drug-bug mismatch from the empiric therapy, that's a wrong match, to have the right match available. Drugs are given at wrong dose for renal or weight-based dosing, and broad-spectrum agents are used to treat very susceptible bacteria, so the opportunity is really with de-escalation. And again, the impact of overuse and misuse is increased mortality, morbidity, and antimicrobial resistance that's accelerated by this excessive use. It's estimated that antibiotic-resistant infections have cost the U.S. healthcare system over $20 billion annually. In slide number 10, this is a recent publication from Clinical Infectious Diseases looking at the Chicago Teaching Hospital area and looking at the mean cost length of stay for patients who had antimicrobial-resistant infections compared to matched controls. There were 2 different groups, the propensity score of 2 and 3. In 2, these were patients who had comorbidities, surgery, and an ICU stay. And in case just that alone did increase the cost significantly. But when you add the healthcare-acquired infection for propensity score 3, the increase in cost was still significant at a p-value of 0.001. So we know that healthcare-acquired infections, on top of the other costs for healthcare, do increase. We move on to slide number, we've got our next case slide in slide number 11. This is a case study that we're going to go through, and we're going to answer at the end of this presentation. We have a 56-year-old white female who's admitted with hypertension, fever, and flank pain. Her urine is showing pyuria and bacteriuria with peripheral WBCs of 16,000. She's admitted to the ICU and empirically started on cefepime. On day 2, her urine and blood grow E. coli susceptible to all antibiotics except ampicillin. The patient is stabilized and transferred to a non-ICU ward, but the cefepime is continued. Cefepime is a very broad spectrum gram-negative antimicrobial agent. Well, on day 5, the patient's going to spike a fever, blood cultures are drawn and grow something, antibiotics are then changed to something, and on day 7, new symptoms develop where the patient's WBC increases to 30,000, new onset abdominal pain, and the patient has developed multiple episodes of unformed stools. So what is the final diagnosis? And we'll come back to this case study at the end of the presentation. Just to right-size this, on slide number 12, the Shea Hickpack position paper defined multi-drug resistant organisms in 2008. Because what we're really looking for here and focusing on for infection prevention are those MDROs which are epidemiologically significant. And this is going to be a different definition than what your microbiology community may utilize as their definitions for multi-drug resistant organisms. So if we move on to slide number 13, these are the MDROs of epidemiologic significance that infection preventionists and your hospital epidemiologists and infectious disease physicians are worried about. For MRSA, it's an oxacillin MIC greater than or equal to 4, or if you have a molecular test for VISA or VERSA, the vancomycin intermediate resistant staph aureus, we've got MIC definitions as well for vancomycin. VRE is pretty clear cut with vancomycin MICs of greater than or equal to 32. But when we get into the carbapenemase producing enterics, there's a definition that was changed in 2011 with the clinical laboratory standards, which changed the MIC greater than or equal to 4, and laboratories may or may not be testing the positive Hodge test to confirm, because we now know that with this lower breakpoint, it's not necessary to always have the confirmation, except if you're interested for epidemiologic surveillance. For ESBLs or the extended spectrum beta-lactamase producers, these are typically E. coli or Klebsiella pneumoniae. Again, they are resistant to third-generation cephalosporins, and the clinical lab standards did change that MIC breakpoint in 2011. So again, if your laboratories have adopted this lower breakpoint, ESBL MIC confirmation may or may not be performed within your hospital labs. Then for Pseudomonas aeruginosa and Acinetobacter baumannii, those organisms that we're really concerned about are the ones that have imipenem or meropenem MICs of greater than or equal to 16, which makes them resistant. On slide 14, I'd like to bring to your attention, in 2008, NHSN published an update on the data of antimicrobial resistant pathogens that were associated with the HIIs reported into NHSN. This report is due to be updated within the next year, and I can share with you an early sneak peek that the gram-negatives are increasing in terms of their frequency of causing healthcare-associated infections. So from the 2008 data, on slide number 15, this table is taken out of this publication in Infection Control and Hospital Epidemiology, and just gives you a breakout that there are 16% of HAIs were due or associated with multi-drug resistant organisms. The top causes were MRSA and vancomycin-resistant Enterococcus faecium. However, the gram-negatives led by Pseudomonas aeruginosa, being resistant to imipenem or meropenem, led the rest of the collection of 4% of the MDROs due to gram-negatives. And again, the newer data that will be coming out from NHSN will show increases in these resistant gram-negatives. So on slide 16, if we break this down just a little bit further, by those MDROs, what's the distribution between device-associated HAIs and surgical HAI causes? And so again, you can see that there is a higher percentage associated with the Staph aureus, which does make sense because Staph aureus is located on your skin and patients are colonized in the nares as well. But certainly with surgical site infections, higher percentage with Staph aureus, although the gram-negatives are very concerning in their association with causing these infections. So if we move on to slide number 17, this slide was taken again from another publication that is listed at the end of the slide deck. If you look at the first line, line number 1, which is Staph aureus due to methicillin resistance, or MRSA, it looks like in the mid-2000s we have actually, that percent resistance has started to slope off. And I think we've seen that as well from several recent publications, one of AGIC, the APIC survey, prevalence survey of MRSA. So it looks like we're kind of winning the battle with MRSA. However, the gram-negative Pseudomonas line 3, Acinetobacter line 4, and even the candidas that are resistant to fluconazole have a very sharp increase now within this last decade and are likely to be escalating, much like we experienced with Staph aureus resistance to methicillin and VRE in the 1990s and into the last decade. Slide number 18 just depicts from the CDC's Get Smart slide from 2001 when the first carbapenemate producing Klebsiella pneumoniae was reported, and within 9 years, almost all states had reported KPCs from patients within their facilities. And you can see from this diagram that in the Pacific Northwest in 2010 there had not been descriptions of KPCs yet. However, that's likely to have changed within the last 2 years. We go on to slide number 19. This is actually a slide deck is taken from the HCUP network from AHRQ, and you can actually go to this website. Hospital discharges where patients were diagnosed with the V09 code, which means they were discharged with drug-resistant microorganisms. You can see from 1993 through the last data set, 2005, a sharp increase in the early 2000s of patients being discharged with MDROs. And you can just imagine how steep that increase has continued from 2005 to present day. Let's take a little bit of time in this section to sort of increase your understanding of what is driving and what causes the resistance in these microorganisms on slide 20. Bacteria have two different types of resistance. One is natural or intrinsic, which is an inherent attribute, and for E. coli, which is a gram-negative rod or gram-negative bacilli, vancomycin, which is an antibiotic with activity against gram-positives, E. coli is naturally resistant to vancomycin. So a translation might be your gender or race traits that are inherent to you. For example, I am a white Caucasian female, so that's my inherent or intrinsic attribute. Acquired resistance is something that is a non-inherent attribute that usually is acquired by genetics, by mutation, evolution, or some received nucleic acid elements that are incorporated into the bacteria. So what happens with acquired resistance is that the antimicrobial agent that was once effective is no longer effective. So, for example, acquired resistance may be Staph aureus resistance to levofloxacin, which is acquired. So if we move on to slide number 21, there are three mechanisms of genetic adaptation. One is transformation, where the free DNA is directly incorporated into the DNA of the bacteria. Transduction, where you have a virus, a replicating virus that's a natural DNA transfer between the bacteria. Or you have conjugation, which is the transfer of genes from neighboring bacteria on a small circular DNA molecule, often called a plasmid. So because bacteria are very prolific and replicate very fast, like E. coli doubles every 20 minutes, you can see that acquisition of these genetic resistance factors is going to be spread very rapidly within a bacterial population. On slide number 22, the 5 different mechanisms of acquired resistance are called drug inactivation, like what occurs with enzyme production, like beta-lactamases or carbapenemases. The second is cell wall changes, which makes the cell wall impermeable to the drug. Altered targets with the mutational change allows for the target agent to no longer bind. Efflux pump, which really expels the antibiotic before it reaches a certain target or certain toxicity level, and then bypass targets where there's actually been a mutational change in the metabolic energy pathway of the bacteria. So let's talk a little bit more about each of these five before we move on. Beta lactases, like ESBLs, are an example of drug inactivation. And the danger here is that it engenders resistance to entire classes of antibiotics, such as penicillin and cephalosporins. Carbophenamases do the same thing, engendering resistance to a class of carbapenems like imipenem or meropenem. So your enzyme breaks these antibiotics down into ineffective molecules before the antibiotic can actually reach the kill target within the bacteria. So if you look at it in common person's terms, the enzyme is like a bolt cutter, so that when the bolt cutter cuts the chain, you have broken the chain and you have a broken molecule which no longer works on the bacteria. We move on to slide number 25. The next type of resistance is cell wall changes, where you've got a target in the cell wall that changes and no longer binds the agent. And this is the example where the cell wall of Staph aureus, the penicillin binding protein, is actually changed from a cup shape to a square shape visually for you to look at, and methicillin no longer binds. So the cell wall changes are really a barrier, in common person's term, like a fortress, to prevent access of the antibiotics. Slide number 27, the altered target means that there's been a mutation so that the antibiotic no longer binds to the target site within the bacteria. So the translation would be that your key no longer works in the door lock. And examples of this type of resistance are gentamicin or erythromycin. For efflux pump, it's kind of like a swimming pool or your pleasure boat, where the bilge pump will eject water out before the drug level or water level gets too high and is toxic to the bacteria. So, for example, this is the type of resistance that's seen in E. coli with Leuclin or ciprofloxacin, where the drug is getting into the bacteria, but the efflux pump is turned on so the toxic levels of the drug are not reached within the bacterial cell. And then lastly, bypass target. An example of this is E. coli and trimethoprim sulfa. The bacteria has actually changed their metabolic pathway. So it's like, in common person's terms, changing your maze by cutting through the wall and just creating another pathway, so that your energy production and your path to your walkway is now changed. So let's transition from the bacterial resistance mechanism description onto what are really some metrics and measures of improved antibiotic stewardship. We know that antibiotic misuse adversely impacts patients with C. difficile. The overuse is contributing to the growing incidence of C. difficile infection in healthcare facilities, and it's the single most important risk factor for development of CDI, as was published a month ago in the CDC Vital Signs. Up to 85% of patients have had an exposure to antibiotics within the last 28 days before infection. Also, the emergence of the epidemic F1 strain of C. diff has intensified the risks associated with antibiotic exposure. This epidemiologic strain of C. diff is associated with increased risk of morbidity and mortality. And the epidemic strain is also resistant to fluoroquinolone antibiotics, which are commonly used to treat patient conditions. And so this is conferring a selective advantage to the F1 strain. So in slide number 31, this recent publication last year in Clinical Infectious Diseases looked at the cumulative antibiotic exposure time and risk of C. difficile infection. So the observations were that there was a dose-dependent increase in the risk of C. difficile infections associated with increasing cumulative dose, number of antibiotics, and days of antibiotic exposure. When comparing to patients who received only one antibiotic, the adjusted hazard ratio for those who received 2, 3, 4, 5, or even more antibiotics rose significantly as you had these overlapping or multiple antibiotics prescribed. The receipt of fluoroquinolones was also associated with an increased risk of CDI, whereas metronidazole was associated with a reduced risk. So antibiotic usage, that pressure of antibiotic usage, is going to increase the risk of C. difficile infections in our patients. On slide number 32, last year the MMWR 2011 published the rates of C. diff infection among hospitalized patients. And as you can see, the older patients are the patients who've had the most significant rates of C. difficile infections over the past decade. And so this report was very revealing and really is showing to everyone who looks at it what infection preventionists have been experiencing with the explosion of C. difficile infections, in many cases outpacing MRSA infections in our hospitals. So this website that you can get the information from is on the CDC GetSmart website. C. difficile infections are a good metric to show the impact of effective antimicrobial stewardship programs. And on the website are these 3 studies showing the decreases of usage and improvements in healthcare-associated C. difficile infections. Many of the other MDRO resistant rates are very slow to change, so it's going to take longer, perhaps up to 2 or 3 years to see different changes in your rates of ESBLs or MRSA rates due to antimicrobial stewardship programs. So if we move on to slide number 34, it starts a discussion on the role of infection prevention science in antimicrobial stewardship. And much of this work is part of the special article that was published in AGIC as well as in SHEA on the collaborative partnership between infection prevention and healthcare epidemiologists. Some of the material is also going to be coming out in a publication in AGIC, which is a longer paper on the role of infection prevention. So it's my pleasure to talk you through and present with you some of the concepts and examples of roles. So certainly we realize that the clinical pharmacists and the physician champions within your facility really have the heavy lifting for a stewardship program, and that epidemiology and infection prevention does play a supporting role, but is actually very important because by applying the skills and knowledge that this subset of professionals has, it will accelerate the progress towards preventing emergence and transmission of MDROs. Obviously, one of the big roles is to identify and report trends and outbreaks of these epidemiologically significant MDROs, and also to be able to provide education for understanding about infection prevention interventions and why they are so important in the bundle of practices to prevent transmission and development of MDROs. Also, the role of infection prevention science is to provide support and guidance and approach to surveillance for some of these syndromes of interest, to implement interventions to guide delivery of evidence-based practices, especially to prevent device and surgical site-associated infections. And lastly, to really translate the data and infection rates to healthcare workers and to our executive administrative leadership within the facility. And I'm confident that each and every one of you in your facilities is already doing this, and this just gives you a more effective way and effective tools to be able to translate that data as well as make healthcare workers, other professionals in this journey, as well as our administrative leaders, very knowledgeable about what infection prevention does and what the value that you add. On slide number 35, this is just a listing and a linkage to all of the APIC care bundles and checklists that the APIC professional group has published and is made available on their website. And this does complement the CDC guidelines as well. On slide number 36, this is really a cross-check of what is your knowledge and skill set. What are the areas that you're comfortable in? What are the areas that I should have knowledge in to be competent in this area? And what are the items that I'm not as comfortable with and I would like more information on? Some of what this does, APIC has, as a professional group, has responded to some of the education needs of their membership, and one of the great programs that has been launched is the Building Bridges, which is a partnership between APIC and the American Society for Microbiology, because there has been such a request to educate infection preventionists on microbiology and some of this information. So if we go through our own knowledge and skill set checklist, are we proficient in evaluating microbiology culture and susceptibility results? Are we able to differentiate between colonization, contamination, and pathogens? Recognize epidemiologically significant MDROs and atypical susceptibility patterns in microbiology results, especially if you are in an area where you have never seen some of these bad bug multi-drug resistant organisms. These first 2 points, partnerships with our microbiology colleagues within our laboratories, is very important because that networking and partnership is a way to improve your skill set, knowledge, awareness, and to have a second set of eyes on some of these MDROs, especially if it's a first-time occurrence for your facility. The other key elements for knowledge and skill set are performing surveillance and trending of your MDROs for prevalent and newly emerging MDROs, to be knowledgeable about the basics for infection prevention of effective hand hygiene, isolation practices, products and procedures for environmental cleaning and disinfection, and also evidence-based infection prevention practice bundles. The other element of not only being knowledgeable, but is to be able to educate and understand healthcare workers and what their knowledge gaps are, so we can explain it and educate them in the best way possible when you are doing your rounding on the unit. The last knowledge and skill set button is to develop and exhibit leadership to promote shared accountability for the highest compliance with practice and multidisciplinary rounding for improved patient outcomes. And this really fits with APIC's 2020 mission of developing leaders in infection prevention and developing you as a leader. On slide number 37, the other roles that we have within antimicrobial stewardship is to collaborate with microbiology, pharmacy, medical staff, and administration in the planning and implementing of effective interventions to prevent the MDRO transmission within the healthcare facilities. Add to your checklist for the year to perform an annual infection prevention risk assessment for MDROs and make an assessment. What are the risk areas for your facility? Is it going to change if you're bringing on a new service line or new business line? We do not forget about the regulatory requirements. The Joint Commission and National Patient Safety Goal in 07.03.01 specifically addresses having a prevention programs to prevent the transmission of MDRO. And just to bring to your attention that there is a proposed new CMS conditions of participation, and within the infection prevention chapter does call out, does the facility have systems to prevent transmission of MDROs and stewardship activities. So each of these new areas of focus are being added to regulatory reviews and regulatory events. So on slide number 38, again, this is to remind me to share with you the Microbiology Collaborative. There's lots of opportunities to improve antimicrobial stewardship, starting right with the specimen collection, having high-quality specimens sent to the laboratory, having appropriate work performed on those specimens, because the results are acted upon by the clinicians and clinical pharmacists. And so good quality specimens coming in means good quality information coming out, and optimizing the use of antibiotics for treating infections and not colonization or contamination. So the point of this slide is to ask you, to ask yourselves is, are we doing the best we can for specimen collection quality, especially urines or sputums that where you've got contaminating microflora, which can cause some challenges. Are the specimens preserved? Do they get to the lab on time so that the bacteria are kind of frozen at the point of collection, frozen in time, so that you don't have overgrowth? And that are some of the rapid tools for microbiology, like gram stain and contaminating epithelial cells, quantified and evaluated to see what the quality of the specimen is. Certainly for identification and susceptibility testing, clinical laboratory standards have some guidelines on how much to work up or what to work up in these specimens. So again, that there are clinically significant pathogens being reported out, and not just a delineation of the non-sterile site microflora that is resident on the skin or resident on mucous membranes. And then lastly, that clinical laboratory standards are used for susceptibility testing and for preparation of annual cumulative antibiograms. On slide 39, certainly if you think you have a novel or atypical resistance pattern for a clinically significant pathogen, make sure that that organism is saved and sent off to a local state health department when indicated, so that you can confirm you've got some of these bad bugs, especially if they've just come into your facility or region. Because this is very helpful to confirm that you do have this resistance reported, as reported by the laboratory, and that it's confirmed. In slide number 40, I'd like to just spend a moment or two talking about a publication last year that was a survey of community-based hospital experiences. And these, the community-based facilities deliver the majority of inpatient care in the U.S. And these are facilities that have beds ranging from less than 50 to up to 250 beds. Typically, they may be located at a distance from major metropolitan areas. But more interesting is that there's limited or no available infectious disease physicians. There's certainly limited availability of trained clinical pharmacists, and only about 700 infectious disease specifically trained clinical pharmacists in all of the U.S. So there's certainly a paucity or shortage within this area. So the take-home message in this survey was that multidisciplinary rounding within a community-based facility often occurs without a physician. So this is where many of you as infection preventionists may be part of that multidisciplinary rounding team and able to share experiences and reviews of each of these patients that you are reviewing. So for example, on slide number 41, you're reviewing all positive blood cultures for NHSN definitions, for HAIs and classes. Certainly collaborating and sharing that information with a multidisciplinary team can expedite identifying which blood cultures are contaminants, and if your contamination rate is too high, what kind of strategy can we implement to reduce those skin contaminants and optimize antimicrobial use. Another example of collaboration is to identify negative cultures when you're reviewing your patients that have devices and the like, and really ask the question, are the antibiotics which are being administered appropriate, or can we look at them for medical necessity and reach out to the prescribing provider to make sure he is aware of the most current culture results and perhaps expedite de-escalating some of the antimicrobials on board. Certainly, part of the collaboration is to advocate for appropriate specimen collection, diagnosis, and treatment of symptomatic UTIs. Treating UTIs, over-treatment of UTIs, is a huge area for stewardship. You can see it when you are performing your reviews for NHSN-based surveillance definitions for symptomatic UTIs. But asymptomatic bacteriuria is a whole group of opportunistic, or a whole group of patients where there's opportunity for improvement in antimicrobial stewardship. And lastly, an example is certainly endorsed computerized physician order entries, because that then drives compliance with evidence-based order sets for different syndromes or diseases and conditions, and helps to optimize stewardship. So on slide number 42, let's go back to the case study that we started with in this 56-year-old female. Well, what happened is that she was appropriately started on empiric therapy. She had finding symptoms of a urinary tract infection and went to the ICU because of her clinical state. On day 2, when the information had come back on her diagnostic testing, the patient was starting to stabilize. Well, the ED had called to the bed supervisor because the ED was backed up with patients needing ICU beds. So the ICU identified that this patient was probably ready for transfer and received the okay from her treating physician to transfer to the non-ICU ward. Because the nurse wanted to help facilitate that transfer in order to get a patient needing ICU care, she followed the physician's orders and entered all of the orders for the non-ICU medical care ward, and that's where the cefepime got continued. So certainly once the patient was admitted to the non-ICU ward, there was a missed opportunity to really de-escalate treatment from a very broad spectrum agent to something that was more narrow that could be used effectively to treat an E. coli, which was susceptible to some of the standard treatment drugs for narrow spectrum drugs for pyuria and urinary tract infection. But because this patient stayed on a broader spectrum drug, on day 5 she spiked a new fever. Blood cultures were drawn which grew Enterococcus faecalis, or they could have grown a Candida yeast. Enterococcus faecalis is resistant to cefepime, as well as a Candida, which is resistant to cefepime. So at this point, her drugs were changed to amsulbactam, and 2 days later, the patient had new signs and symptom onsets for C. difficile infection. And so you can see the outcome of a healthcare-associated Clostridium difficile infection. The patient also has an HAI blood stream infection due to the Enterococcus faecalis. So we've got 2 HAI hits here where we may have had the opportunity to prevent C. difficile and the Enterococcus faecalis bloodstream infection in this particular patient. So the takeaways really from this presentation for you is to evaluate your infection prevention knowledge and skills, identify where you've got education and experience gaps to fill, and seek out those resources, whether it be from professional APIC resources, whether it be from presentations that are offered, such as this WebEx, or other collaborative resources within your region. Secondly, evaluate your infection prevention plan and incorporate stewardship activities and MDRO reporting within your annual infection prevention plan. Example would be if you have never seen or experienced a carbapenem-based producing enterococci or Acinetobacter within your facility, your infection prevention plan could simply state that you are going to collaborate with microbiology to make sure that you identify the first index case that comes into your facility, versus looking at putting into your plan for reducing healthcare-associated C. difficile infections. If that's a particular problem within your facility or a unit, that may be your infection prevention plan associated for that MDRO. And then lastly, increase your visibility and leadership in infection prevention and antimicrobial stewardship by adding the value and the knowledge that you have into this rich environment. So on slide number 44, I've just provided a few resources from CDC, and also there's some a resource on the WHO site. And then lastly, this publication in AJIC, which was the special article jointly published by Infection APIC and the Society for Healthcare Epidemiologists. So with that, I would like to close, and I think we will be ready for questions.
Thank you, Julia. This is Jennifer Pelaggi, and I just really appreciate your presentation. I think Jenna was getting ready to say something there.
Thank you, Julia.
Well, I'm checking out the chat line, and I don't see where we have any questions that are pressing right now. So while we're waiting for folks to use the last 5 minutes or so for questions, I'll just go ahead and, Julia, if you could forward on there, and I'll just announce to people that the upcoming topics are going to be hand hygiene in June, same day of the week, same time. And we will be talking about hand hygiene programs, particularly some around engaging patients and families, but it'll be a broad overview as well. And it was by no accident that we lined up April with C. difficile, and then May with antimicrobial stewardship, and then June with hand hygiene. I think those topics go well together, and we're getting a great response from folks in participating in the webinars. And also, just to remind everyone, all of these webinars are recorded, and we post them as soon as we can on the Intermountain APIC website, which is www.apicintermountain.org, or .com, sorry, I always say org, apicintermountain.com. And we also put handouts and other materials out there as well. Do we have any questions right now on the phone? No, ma'am, there's no questions. Thank you. A couple that came to my mind, I really enjoyed this overview, and we have so many settings that pay attention to these webinars. Julia, what would you say, let's think about the long-term care or the nursing home environment right now, where maybe there's lots of them that don't have a strong antimicrobial stewardship program, if any at all. I kind of like what you were saying about it. I would just ask, what would be a good first step for them? You know, there's somebody who's wearing multiple hats as an infection preventionist and a staff nurse, and maybe even the director of nursing. But would it be to start going through a list of patients who have antibiotics? What would you suggest for the first step in their program?
That's a great question, and really, you would have to look at it. What do you want to go after? What is your biggest problem? And how do you want to approach it so that you can gain some success? Because there will be barriers to the antimicrobial stewardship initiative. So certainly look at, is it urinary tract infections that are being treated? Are they being treated appropriately? What's your C. diff rate, that kind of a thing? Is antibiotic usage driving some of your C. diff rates? So kind of really assessing what's the best fit, what's the best need for your facility. Then going out and using some of these pre-done resources that are available on the CDC website, and then partnering with your leadership there, whether it's your director of nursing, the physician lead for the facilities, and really coming up with the best plan to approach some of these MDROs.
Great. I also see a comment from Mike Brown on the chat line that says, at SHEA this year, 3 related data points were suggested. I think this was in response to my question. Number 1, give indication for antibiotics. 2, review at 72 hours. And 3, IV to PO.
Right, those are all low-hanging fruit to look at. Again, the indications of the antibiotic, is it appropriate? UTIs are a good example of overtreated disease syndrome. Review at 72 hours is like a antimicrobial holiday. You should have most of your microbiology results back at that time, so it's a good point to look at, can we de-escalate or can we actually just continue antibiotics? And then IV to TO, yes, that's a good indicator to go after, if it's appropriate, changing these patients to an oral antibiotic or to be able to reduce the duration.
Now, operator, do we have any questions on the phone lines?
No, ma'am, there are no questions in queue. Again, ladies and gentlemen, if you have questions on the phones, please press the number 1 key.
The other thing that I was thinking about, this is Jennifer, is that, and for those different settings, you might be looking at a different type of champion who is leading the team.
Absolutely.
If you have a group of people together, a team who are addressing this topic in your facility. So in your larger hospitals, your PPS hospitals, who would typically be the leaders on your team that you would be a part of? And then in nursing homes, who might be the champion?
Well, certainly within an acute care setting, as you can see from the survey, some facilities don't have an infectious disease physician. So it could be that you might have a hospitalist within an acute care setting, or in a nursing home, you may have a primary care physician. That there's quite a bit of work that's been done in the outpatient setting with the CDC Get Smart program. So those are all good resources, and alternative champions that are non-traditional physician champions you may not think about. And then outside of the physician role, what specialties are available with the expert knowledge? Is there a pharmacist available by consult? Is there case management, nursing, infection prevention? So some of those other roles and responsibilities with their expertise that are going to be able to put their heads together.
Julia, this is Jenna. Just a question, we are a pretty rural hospital, and our antibiogram includes the nursing homes because all of their cultures come through our lab. So, as we reach out to them as infection preventionists to educate the staff that are doing infection prevention, it might be a good idea for us to for our physician champion here on the antimicrobial stewardship to reach out to their doctor, because each one of them have a doctor that's over their facility. That might be one way that we could help educate them too.
That's a great example. Also, if between the acute care facilities and the skilled nursing facilities, if you have a quarterly nursing summit where nursing is talking with nursing, and even your facility CEO as a leader in healthcare can even reach out, and you can actually start your own regional networks and initiatives.
Yeah.
Great suggestion.
Operator, do we have any questions?
No, ma'am, there are no questions in queue.
Well, I definitely want to make sure that we're respecting everybody's time, and we are on the hour now. And I want to make sure that you folks, I just remind you, I had a question, how do we get CEUs? I have a sign-in sheet that we email to everyone along with their handouts. It was a separate document. If you need that, just let me know. If Julia, if you move on to the next slide, there's some contact information there. Jennifer at QualisHealth.org. I can get you those materials if you didn't receive them. Also, again, you can go to apicintermountain.com for materials, and we also put the sign-in sheet on there as well. Also know that when you close out, you'll be offered a Survey Monkey. Please let us know in 30 seconds or less how you felt about the presentation. Fill in a few of those, strongly agree, disagree, whatever, so that we can make sure that we make this the best experience as possible. And also related to this topic, the Washington QIO, which is Qualis Health, but they really focused in the last few months on doing a virtual field trip webinar series to a variety of Washington hospitals who talked in depth about how they grew their programs. And so those were recorded. Those are also available on the apicintermountain.com site. And that was a fabulous, fabulous antimicrobial stewardship series, and really hearing from people who have put something in place from large to small hospitals. Julia, I just want to say thank you for giving us your time and your knowledge and expertise today. It's so valuable. I'm already getting great feedback from folks over the chat and even in my email box. I can't express how much we appreciate you being on the line with us.
Well, thank you for the opportunity.
So with that, we'll just go ahead and sign off, everyone. If you have any questions or comments that you want to pass on to Julia, her email is right there, so do so. Or you can pass them on my way. Everybody have a wonderful afternoon, and we'll see you on the next call.
Thanks, Jennifer.
Thanks, Jenna.